Today we will discuss some of the points related to PEG-Interferon use in chronic hepatitis B management. It was initially used frequently, but now it has gone out of favor due to some reasons, but it is a very good drug. So if you look at the chronic HBV treatment endpoint, there are various definitions, but in the end we have to target HbA_Cg loss. So functional cure is defined as HbA_Cg loss confirmed on 2 occasions at least 6 months apart with HBV DNA negativity. This is the functional cure, and this should be the target of every therapy for chronic hepatitis B infection. Now HbA_Cg levels are very important because these are related to the risk of HCC, and as can be seen, the relative risk for HCC increases as the HbA_Cg levels increase, and when HbA_Cg levels are persistently above more than 10,000 IU, then the risk is 2.9 times. So also in E negative patients, when DNA is less than 2000, HbA_Cg levels more than 1000 are related to higher risk of HCC, even in so-called the inactive carriers, which was previously the term used. So why functional cure is important? Because HbA_Cg seroclearance decreases the risk of HCC. This was a very large study on nucleoside analogs therapy. As can be seen, patients who had HbA_Cg cleared had very low risk. Patients who had complete virological suppression versus patients who had some amount of viremia persisting, they had higher risk. But the target is HbA_Cg loss, but there is low HbA_Cg clearance with nucleoside analogs. If we use long term, then also 3 to 5% at most. So if you look at the treatment regimens using PEG-Interferon, the standard is 48 weeks injection. There are many alternate combinations and alternate regimes have been studied, we will see. And there are certain advantageous groups who have higher chance of response, and we should try to focus on these groups so that we get a higher chance of response. And there are certain groups with very low chance of response, and we should apply stopping rules in them. So if you look at the standard and alternative regimes, standard regime is 48 weeks. Alternate regimes are extending the duration to 72 or 76 or 96 weeks. Combination with nucleoside analogs, either we start initially simultaneously or add on PEG-Interferon or switch after initial short or long period of nucleoside analogs. There is a concept of intermittent PEG-Interferon therapy also, and there are other advantageous groups. For example, E antigen negative patients with normal ALT, HBV DNA less than 2000 and low HbA_Cg levels. Postpartum women, very interesting group, and patients developing clinical response after long-term nucleoside analogs withdrawal, because naturally they are developing immune response. So at that time, if we try treating with interferon, the chances of HbA_Cg loss is very high. And in combination with the newer agents, because newer agents are being developed and they alone seem to be not very effective in HbA_Cg loss, so interferon plays an important role in that subset also. So if we look at the standard regime, overall responses are in E antigen positive patients. After 6 months after PEG-Interferon discontinuation, 23% will have E antigen loss. This is not HbA_Cg, E antigen loss, and 81% of the E antigen loss remains sustained by 3 years after PEG-Interferon discontinuation. Now 6 months after PEG-Interferon discontinuation, the loss is very less, about 2 to 7%, though more than nucleoside analogs, but still less. And if we look at the 23% of patients who had lost HbA_G, they lose HbA_Cg loss by 3 years among patients who lost HbA_G is overall about 30% of the patients will lose. It is also dependent on the genotype. Genotype A 58%, whereas in non-genotype A it is very less, 6. Now there have been studies on ultra long-term HbA_Cg responses in E antigen positive patients, and this was a study from Canada, 267 patients treated with conventional interferon alpha 2A and alpha 2B, and in combination also. And ultimately it has been shown that about 1/3 of patients will lose HbA_Cg if they had exposure to PEG-Interferon. This is quite high. and by 20 years about 40% may lose. And these were the factors that were associated with higher loss. Now, if you look at the E antigen negative patients, after 40, about 12% will lose HbSAg after 5 years. This was the initial registration trial of 537 patients. Then PEG-Interferon alpha plus placebo limb, 6 months after PEG-Interferon stoppage, HbSAg was only 3%. But after 5 years in this limb, about 12% will lose HbSAg in E antigen negative patients. Now, if you look at the predictors of PEG-Interferon alpha response at the baseline, so in E antigen positive, low HBV DNA, high ALT levels, genotype A more than D, B better than C, and high activity scores of liver biopsy. Similarly, in E negative patients, high baseline ALT, low DNA, young age, female gender, and genotypes have also some influence. But negative predictive value and positive predictive value of these variables are at baseline are very low. So, these cannot be used for stopping or continuing rules. So, we have to see on treatment predictors. There have been on treatment predictors also in E antigen positive patients at 12 week. There is very low response if there is no decline of HbSAg in genotype A and D, almost 97 to 100% negative predictive value, and in genotype B and C, each HbSAg remains above 20,000, again high negative predictive value. At 24 weeks, if HbSAg remains more than 20,000 irrespective of genotype, negative predictive value is 99%, and this can be used as stopping rules at 12 week and 24 weeks. Whereas in E negative patients at 12 week, if there is no decrease in HbSAg and less than 2 log decline in DNA in genotype D, 100% negative predictive value, better to stop. At 24 weeks, less than 1 log decline in HbSAg, this for genotype B and C, again very high negative predictive. Now, what about extending the duration of treatment? So, there have been in E negative patients, extended duration therapy 96 weeks has been shown to be better than 48 weeks. There have been 3 studies in varying genotypes, genotype D, B, C and E, and the highest HbSAg clearance was shown from Chinese study, about 35.7% for 96 week therapy as compared to 10.5% with 48 weeks therapy. Whereas in others, though 96 weeks therapy was shown to be having higher HbSAg loss, but the overall incidence was less. Now, stopping rule can also be used for extended duration PEG-Interferon, and for E negative, HbSAg decline less than 1 log at week 24. Then, if more than 1 log decline, then very high HbSAg loss. Whereas if there is less than 1 log decline, there is low HbSAg loss. So, this can also be used as stopping rule. Now, but in E positive patient, the extension of the duration of PEG-Interferon has not shown to be effective in promoting either E antigen loss or HbSAg loss. This was the study from China, genotype B and C, and at 24 weeks, patients who were early responders, they were continued on PEG-Interferon for 48 weeks, whereas non-early responders, that means, and they did not achieve HbSAg less than 1500 IU and HBV DNA less than 5 log copies at week 24. They were randomized into 3 groups. One group continued for 48 weeks and the other 2 groups for 96 weeks, one with addition of adifovir, and as we can see, HbSAg loss was similar in all the groups, and E antigen loss was also similar in all the groups. So, E antigen negative extension of duration of therapy is beneficial, but E antigen positive there is no benefit. This was a meta-analysis published in 2020 of 9 RCTs. So, overall HbSAg loss was 11%, in E antigen positive 14% and E antigen negative 10%. Now, then there is a combination of PEG-Interferon and nucleotide analogues. Initial, that is they starting both the drugs simultaneously. So, this was again the meta-analysis which showed that initial simultaneous PEG plus NA combination has higher HbSAg loss as compared to the NA monotherapy. HbSAg loss is about 15 times more odds ratio is 15.59, E antigen loss is 1.6 times. So we can see HbA1c is quite high as compared to the NA monotherapy. Now, as compared to the PEG-Interferon monotherapy, the combination, whether it leads to higher HbA1c loss, is controversial. One meta-analysis suggested that initial combination therapy was same HbA1c loss as compared to PEG-Interferon monotherapy, whereas another very recent meta-analysis in 2024 suggested that initial combination therapy had higher HbA1c loss was as compared to the PEG-Interferon monotherapy, about odds ratio of 2. So now another strategy is to add on PEG-Interferon or switch to PEG-Interferon in patients who are already on nucleoside analogs. So again, there was a meta-analysis which showed that as compared to the NA monotherapy, add-on had higher, about odds ratio of 4.5 for HbA1c clearance and 2 for HbA1c loss, whereas for as compared to the interferon monotherapy, similar HbA1c loss. So as compared to the nucleoside analogs, PEG-Interferon is better, but for PEG-Interferon monotherapy, the combination is same. Now we have to find a group in which HbA1c loss can be achieved in higher proportion with add-on therapy. Then we can see that if at the time of regime conversion, that is addition of PEG-Interferon, if HbA1c levels are low, for example less than 178, then the annual HbA1c loss, this is annual HbA1c loss, 14.4% per year. Even if it is less than 1000, then it is about 10.6% per year. So quite high actually. Now this was a study from ILBS published by Dr. Ankur in 2018, which showed that E antigen positive chronic hepatitis B patients, they initiated tenofovir for 12 weeks initial lead-in period, and then randomized to either continuation of the tenofovir or combination with PEG-Interferon up to 36 weeks, then follow-up. And as can be seen, E antigen loss quite high, 35.8% in the combo group, whereas in the monotherapy group it was 17%. Whereas HbA1c loss 5.6% in the combination, and HbA1c loss was none in the monotherapy group with tenofovir. Now again meta-analysis has been published on this topic, which showed that switch to PEG-Interferon leads to higher HbA1c loss as compared to the continuation of nucleoside analogs. Now HbA1c loss is 12 times, relative risk of 12.15, E antigen loss, whereas the others are similar. Now again annual HbA1c loss with switch to PEG-Interferon, depending on the HbA1c level at the time of conversion, if less than 1500 IU per ml, then the annual HbA1c loss is to the tune of 20% HbA1c loss is occurring. So it all depends on the HbA1c level at which PEG-Interferon is started. Now as compared to the PEG-Interferon monotherapy and switch to PEG-Interferon is similar HbA1c loss. So again HbA1c loss is similar, odds ratio not significant, but it has higher E antigen loss, DNA undetectability is higher, and ALT normalization is higher. Now there have been also been published scores to predict HbA1c loss in add-on versus switch to PEG-Interferon in both E positive and E negative. This is large prospective study from China. In this study, end of treatment HbA1c loss was 16%. So this formula is for end of treatment HbA1c loss, not long term, and depends on the age, baseline HbA1c decline at 12 weeks, and ALT ratio at 12 weeks. That is how much ALT is above upper limit of normal, and if score at week 12 is more than 4, then 37% end of treatment HbA1c loss. So we can find some group of patients where interferon will give very high HbA1c losses. Now this was the study which compared switch to versus add-on PEG-Interferon, and this was a RCT from Singapore, and which included patients with long-term nucleoside analogs and HBV DNA negative. So add-on PEG-Interferon versus switch to PEG-Interferon. HbSAg loss was 10.1% in add-on, switch to also same, but none in the control, that is continuation of nucleoside analog therapy. But viral relapse and clinical relapse, they were much higher in switch to PEG-Interferon as compared to the add-on. So, it is better to add on rather than switch according to this study. Now, the interesting concept of intermittent PEG-Interferon therapy. There is only one study, but it shows that very high HbSAg loss can be achieved. In this study, PEG-Interferon was given for 24 weeks. Then, among the patients in which HbSAg levels decreased less than 0.5 as compared to the baseline, they were started on entecavir or tenofovir for 3 months, 3 to 6 months, and then restarted PEG-Interferon for 72 weeks. And then entecavir and tenofovir was continued. So, overall about 20% had HbSAg loss after 70 at this time point after 72 weeks of treatment, and patients who had a decrease of HbSAg more than 5 log at week 12 in the retreatment phase, they had more than 40% HbSAg loss. Now, we should see other advantageous groups. Now, there was a meta-analysis in 2021 comparing PEG-Interferon in E antigen negative chronic HBV infection, not chronic hepatitis, but in HBV infection, that defined as HbSAg positive, HbSAg less than 1500. Again, HbSAg levels are very important. E negative, anti-HBV positive, negative, DNA less than 2000, and normal ALT levels. So, HbSAg clearance after 48 weeks of treatment or follow-up, PEG-Interferon 47%, and in control groups about 1.5%. It depends on the levels of HbSAg. If levels are less than 500, reaching up to 60%, if less than 100, 73%. So, if less than 1500, still about 50% will lose. But these all were retrospective studies, and though no RCTs are available, but these give very encouraging data for use of PEG-Interferon in this group. Now, postpartum women, this was a single study only in postpartum women, and interferon use is not contraindicated in postpartum period, it can be used. In China, this study was done in China. All E antigen positive patients at 3 months they were assessed, and patients who had ALT more than up to twice upper limit of normal and E antigen titers decreased by more than 20% as compared to the last trimester of pregnancy, and HBV DNA levels decreased by more than 2 log. Then they were randomized to 2 groups. Either LDT was stopped in one group, and in another group they were shifted to PEG-Interferon and adifovir for 96 weeks. And as can be seen, so week 96 HbEAg loss reaching up to 56%, week 96 HbSAg loss also reaching up to almost 26 or 30%, whereas in the control group none of the patients achieved these milestones. But in this study there were no groups who developed favorable characteristics but were not treated. So, this is lacuna of this study. Now, in the same cohort from China, in the same genotypes, spontaneous HbSAg loss has been reported in about 14.4%. So, use of PEG-Interferon leads to significantly higher as compared to the if no interferon is used. So, this is one group where it can be used. Now, patients developing clinical relapse after long-term nucleoside analogs. This was again, this is only one study from ILBS done by Karan, Dr. Karan, and very recently published. So, long-term nucleoside analogs stopped in 118 patients, and fibroscan was less than 8 in all the patients, and they were on nucleoside analogs for at least 2 years and undetectable DNA on 3 occasions, and almost 70% developed clinical relapse, and 44 patients who developed clinical relapse in the initial 12 months, they were treated with PEG-Interferon, whereas other patients were treated with TAF. So, among these patients, 31% developed clinical relapse after stopping PEG-Interferon, they were started on TAF, and median follow was reaching up to almost 5 years. And as we can see, at the end of last follow-up, HbA1c negative in 15.9%, but HbA1c levels less than 100, which is itself a predictor of future HbA1c loss, is reaching up to 36.4%. Again, in this patient, stopping rule can be applied. HbA1c less than 1000 at 3 months after interferon, 80% will develop HbA1c loss. If no, then only 7%. So these stopping rules can be applied. Now, it can also be used in combination with newer agents, and these are the various potential strategies that are being investigated to achieve functional cure. But the most advanced is bepirovirsen, which is an ASO drug, and it has reached up to phase 3 also. And this was the first trial in NEJM that was published. So, B-Clear study, bepirovirsen, antisense oligonucleotide that targets all HBV RNAs. And the primary endpoint was HbA1c level undetectable, DNA levels less than 20, 24 weeks after end of bepirovirsen treatment. And there were 4 groups, one 300 milligram for 24 weeks and another 300 with followed by 150, 300 for 12 weeks followed by placebo, and placebo followed by bepirovirsen. So, as we can see, HbA1c loss is only 9 to 10%, maximum 10% in any of the groups. So, another study B together was planned, which is sequential bepirovirsen followed by PEG-Interferon. And these were 2 groups, bepirovirsen for 24 weeks in one group and followed by PEG-Interferon for 6 months, and another group 12 weeks bepirovirsen followed by PEG-Interferon. And the primary outcome again was HbA1c loss and DNA less than 20, 24 weeks after the end of treatment. And as can be seen, if you look at overall in the 24 week versus 12 week, overall the HbA1c loss is quite less, 9 and 15, but based on HbA1c levels, if baseline HbA1c level is 3000, then 14%, if less than 1000, 24%. So, as compared to the bepirovirsen alone, addition of PEG-Interferon leads to higher HbA1c losses. So, to summarize and what should we do, I will show you some algorithms. So, when should PEG-Interferon be considered? If we know that there are favorable predictors of response, so that low HBV DNA, high ALT levels, genotype E, and specific patient demographics, for example, generally young people, young women who want pregnancy in the near future, though we have to remember that pregnancy is contraindicated for at least 1 year after the last dose of PEG-Interferon. There should be no comorbidities, patient preference. If concomitant HCV or delta infection, then obviously it may be drug of choice. But a careful patient selection and individualized treatment decisions are required to achieve treatment optimization. So, E antigen positive treatments, 48 weeks PEG-Interferon is preferred. Apply week 12 stopping rule. If no HbA1c decline in genotype A and D or HbA1c levels more than 20,000 in B and C, stop. If no, then continue. Then look at week 24 stopping rule. At week 24, if HbA1c levels more than 20,000, again stop, otherwise continue for 48 weeks. E antigen negative treatment, 96 weeks PEG-Interferon is preferred, but if we want to use 48 weeks, then week 12 stopping rule should be applied. No decline in HbA1c plus less than 2 log decline in DNA for genotype D only, stop interferon, otherwise continue. If we plan to use for 96 weeks, then 6 months stopping rule should be applied, less than 1 log decline in genotype B and C. If no, continue for 96 weeks. And if this milestone is not reached, then start nucleoside analogs. Then intermittent PEG-Interferon can also be used after 3 to 6 months of continued nucleoside analogs. If decrease in HbA1c more than 0.5 at week 12, continue. You will have very high HbA1c losses in this limb. Otherwise, stop PEG-Interferon. Similarly, add on PEG-Interferon for 48 weeks when HbSAg levels are low. So at the time of addition, if HbSAg levels are less than 1000, then about you can have HbSAg losses as high as 20% per year. Again, E antigen negative chronic HBV infection, because the world is moving towards probably treat all patients, all HBV DNA positive. So again, treat if at the time of starting interferon HbSAg levels are less than 1500, you will have about 20 to 25% per year HbSAg losses as compared to no treatment or nucleoside analogs treatment. Now, patients who develop E negative who develop clinical relapse after long-term nucleoside analogs withdrawal, 48 weeks PEG-Interferon should be used. If we can apply week 12 stopping rule here also, if HbSAg levels are more than 1000, then stop, otherwise continue for 48 weeks.